Hello, everybody. Thanks for joining for our second session of our Dementia 3D Echo series. Today, we're going to focus on signs and symptoms of cognitive impairment and cognitive assessment tools, focused on tools and evaluation, within the primary care setting, but also tools and assessment within residential settings like nursing homes as well. So really trying to take a universal look at this. Just a little reminder about continuing education. So for nursing, continuing education hours are eligible here. Disclosures, again, same as last time, nothing new is added here. Announcements, Amber, anyone else have announcements they want to?
Just a reminder that all of these sessions are recorded and they are placed on our website. So I'll throw that into the chat box for you. And that we love to give continuing education credits, but you do have to complete the survey. So we want to hear how we're doing. So make sure you complete that so that we can give you appropriate credit. That's about it for me.
Wonderful, thank you. Yeah, and just a reminder for folks for future sessions, and even if it doesn't fit exactly, it doesn't have to fit, a specific topic that's on the week, but submit cases, use that case presentation form online and submit a case. You don't have to have all the information, just fill it out as much as you can, but more cases, the better. Gives us some substance and some concrete examples to go over together. I think people always find those really useful. Just a reminder of our schedule. Again, this is today's a second session of 10. So we're still getting the series just kicked off. And so, our normal 3D Echo or Project Echo format, we'll get started with a didactic, focus on some teaching topics, and then we'll jump into any cases. I don't think we have a case that was submitted specifically for today's session, but if you can think along the way, if you can think of a case, even if you want to do it on the fly, I mean, that's perfectly acceptable. Otherwise, we'll definitely use the time for some discussion with everyone here. Let's jump in. So signs and symptoms of cognitive impairment and cognitive assessment tools. And again, with credit to Alzheimer's Association for providing the slides and the bulk of the material. So today, what do we want to do? I really want the audience to be able to recognize the benefit of early assessment. We want to be able to detect and diagnose cognitive impairment as early as possible, because that's what confers the best chance for intervention and improvement, regardless of underlying issue. Remember that. So even if the person does have dementia like Alzheimer's, earlier detection still drastically improves their outcomes. So we want to be able to recognize the benefits of that, identify who are these people, who are the ones that you want to be assessing for dementia or cognitive impairment, and then the use of brief cognitive assessment tools. We'll get into some detail there about what can you do in your locations, whether in the primary care clinic or in a residential setting. What kind of tools can you rely on to detect cognitive impairment? So just to kind of drive it home about benefits of early identification, what happens to any of us really if we have cognitive impairment? Regardless of age, a lot of people now are suffering, for example, from COVID brain fog, at all ages, but any driver of cognitive impairment, whether you've had a TBI in the past. I mean, what happens? It makes it a lot harder to go about your day, right? It makes it a lot harder to just remember your appointments, remember what you're doing, perform well at work. Now imagine, you're older and you are, in the later stages of life and you have some cognitive impairment, already dealing with maybe some other comorbidities, medical issues, maybe you have hypertension and diabetes, you're supposed to be using medications for, those start to slip through the cracks. So you can imagine, cognitive impairment, no surprise, affects all areas of life. So the more that's why we really want to drive home, the more we intervene, even if someone's already in a residential setting, they're being prompted for everything, and they're really well taken care of. But still, it drastically affects quality of life. And there's really nothing, there's only so much we can do. Sure, we can prompt people to take their medications and get up and move and things like that. But cognitive impairment, as it increases, your mobility, your interest, your engagement all goes downhill. And there's only so much you can do, right? I mean, we can't really force people to increase their quality of life in every way. So again, it's sometimes it's hard for me to even imagine or really take into consideration the impact of cognitive impairment. Even if I had infinite resources, the treating those underlying causes is really where you get the best benefit. And so this is just pointing out, safety in using insulin. Someone with cognitive impairment, especially when you're using risky medications, definitely opens the door for some medication errors. Things that come up very frequently, right? Driving, probably the hottest topic, the most difficult topic that comes up with patients. For those of us in the clinic, in a primary care setting, when we're first screening patients, even for patients that are in assisted living in certain residential facilities, right, who still want to have access to their independence and driving, really difficult topic. The earlier we detect that impairment, the earlier we start the conversation, boy, does it go smoother, having, making adjustments, accommodations to eventually transition to not driving. But, the later it happens, the more of a surprise it is. And sometimes the more the cognitive impairment is at that time, it actually tends to be harder, because as somebody starts to lose their insight and their ability to engage in that conversation later in the course, that driving conversation all of a sudden is much harder. Whereas earlier in the cognitive impairment, people tend to have insight, so they'll recognize, oh, wow, I don't want to be a danger to myself or others. And so that makes it a lot easier to have that conversation. Independence, living alone, and then we mentioned elder abuse, financial abuse. I mean, does that, is that the majority of times? Of course not, but it certainly does happen. I mean, I do see it, unfortunately, on a routine basis where, people are losing track of their money. You just have to keep in mind, there's so much kind of phishing and fraudulent stuff going on out there. So you can imagine we've all kind of thought about, especially this day and age with technology, our grandparents or someone who's vulnerable getting taken in by, emails and that kind of stuff. Happens a lot. People really are out there taking advantage. And then the whole living alone thing, I mean, really becomes difficult. And especially in rural areas, most parts of Montana and Alaska and Wyoming and Hawaii, it's kind of hard to detect because people are out there. They'll have a really strong sense of independence because they've had to. And so sometimes it can be hard to think about what those resources are. But again, the earlier we start, the more we can do there. And then earlier identification helps with workup. So again, and we'll touch on this more throughout this series. I kind of threw in some specifics here, but medication effect. Again, let's say I have someone that's in their 60s coming through the door, and I'm detecting cognitive impairment. I'm worried about underlying neurodegeneration, and it's in the early stages. I'm going to hit hard at their medication list to remove anticholinergics. What do we mean by those? Basically, think of Benadryl or anything related to Benadryl. We use them all the time because they help dry up your allergies, dry up your bladder if you're having urinary issues, GI issues. So we use them a lot, and we tend to use them in the younger years, kind of more just liberally. We don't really think about it, like, oh, I'm just gonna take some Benadryl to go to sleep, or Unisom, or I'm gonna use this medication for my bladder. Well, once your cognition starts to suffer, we really got to pretty aggressively move away from those, because it does directly impact your cognition. The Beers criteria, very well known, been around many, many years now, publicly, updated every few years. I don't think it's updated every year, but those are a very comprehensive list of medications and risk level for geriatrics and what we should avoid. So if you ever want to look it up, that's a good way to do a little cross-reference. So even if you're not a prescriber, again, it's very helpful to have non-prescribers point them out and say, hey, I noticed this patient's been taking Benadryl over the counter. They may not have even mentioned it. Maybe it's not on their med list. Maybe they didn't tell their provider. So it's helpful to have more eyes on it and say, did you know they're taking Benadryl every night to sleep? I can't tell you how many times that's happened. And I can't tell you how many times we've removed it and seen a direct improvement in not just their subjective cognitive experience, but also their actual cognitive test scores. You'll see it. I mean, these are measurable changes you can see. So it's really reinforcing. Endocrine, metabolic problems. Again, part of standard workup early in the course, TSH, thyroid. stimulating hormone, doing that workup, vitamin B12. These are the more common reversible causes. But again, you want to think about back in the older days, we used to check more routinely for things like syphilis, because neurosyphilis was much more common, could be dormant for a long time. But again, you want to think about, there's a long list of things that could cause issues: depression, anxiety, sleep apnea, anything affecting your day-to-day, your diet, if you're malnutritioned, right? All of this stuff can contribute. And so again, early identification really prompts you to think about those things. And so really the most important thing here to remember is all of those things we just talked about are treatable. There's interventions to be provided, and people do better. So that's really the most reinforcing thing. That's what's most rewarding about what I do and why I like doing it. And I keep working with cognitive impairment, memory loss, is because I see time and time again on a routine basis, people having improved quality of life, reducing their hospitalizations, keeping them healthy, keeping them independent. The best part about this is, our priorities are very aligned. I always tell people, I don't want to ever see you again. You stay at home, you stay independent. That's great. We're on the same page about that. And the earlier we get started, the more of a chance we have to do that. And then obviously respecting patient autonomy, their ability to participate, right? If they're suffering from dementia already, they're really not going to be able to participate in the decisions, not nearly as much. We have to rely more on historical knowledge or family members, things like that. Just, it adds a layer of tension. But many patients are lucky that they have good support in their lives. Time to develop relationships with doctors and care partners. A lot of what we'll do in this series too is kind of help guide, well, what should you be asking as a caretaker, caregiver of a patient? What should patients be asking? Helping navigate. I mean, it's a really difficult topic. It's scary. You live your whole life, you build an entire history, and then you're faced with, losing your cognition. I mean, it's really, for most people, that's about the scariest thing you can imagine. And so helping navigate that anxiety, again, starting earlier really goes a long way. And then this kind of participating in clinical drug trials, helping advance research. That's a big topic. I've been working on clinical research really throughout my career. And, in the dementia world and the memory care world, on one end of things, we're always saying, man, when are we going to see the next new drug, or when are we going to get some more help? But on the other hand, then how can we, if we don't detect people early and accurately label and diagnose and categorize, diseases? So it's a two-way thing. We really got to do a better job here helping characterize our population. That then opens up the possibility for more research and more drugs. So I am very optimistic that we are in an era where we're going to be seeing several, hopefully many new drugs and many new treatments. But we really, as a community, even though we're not directly participating, our roles are still very much critical, because even if I'm in a residential facility or a clinic in a rural area of Montana, if my population is characterized well, that's going to speed up patients' access to new research, but also new drugs when they are FDA approved. So who should be assessed? Individuals with memory concerns or other cognitive complaints. Literally anybody that has any kind of memory issue, whether it's a caregiver or family member bringing it up, whether it's a patient, or whether you as a healthcare provider have an issue or a concern, that's a person that should be assessed. And we'll talk about what that assessment looks like. You really don't have to have any other reason. So individuals with non-memory concerns, such as personality change, depression, deterioration of chronic disease without explanation, falls or balance issues, keep in mind, cognitive issues for everybody doesn't mean they're going to show up and say, hey, I'm forgetting, to go to my appointments. They might have a personality change. Frontotemporal dementia often presents as personality change, apathy, loss of interest in activities, sometimes overlaps a lot with depression. You might have some visual hallucinations, visual issues. I mean, there's all kinds of different dementias early on, and they don't all present with, classic memory issues. So just keep that in mind. We have dysexecutive syndromes, frontal lobe issues where they're having trouble making judgment, decision-making, personality change. We have, Lewy body type of pathologies where you have visual processing issues, even hallucinations, REM sleep behavior disorder at night. things like that. So just having, got to have an open mind with, but the key is something unexplained, something's kind of out of the usual, and it's been maybe a slow progressive decline. Informants are extremely important, right? It doesn't matter if the patient agrees or not, but if an informant, you trust, whether it's a long-term partner, a child, someone who obviously knows the person well, or a very good friend, if they've noticed some gradual or chronic decline, that's definitely worth exploring. And often with our older patients, if they show up alone and there's any hint of concern, I get on the phone and I find an informant. I had one person, who just was adamant that they had no one that they could bring in with them. And so I insisted, and finally they actually brought in this person for the previous 6 years they kept running into at the YMCA where they went to the gym. And so they brought him in, and guess what? It was super helpful. That person noticed in those 6 years a clear decline, and this person had been living independently, and there was an underlying dementia going on. So I can't overstate that. Definitely have an informant. No matter what you have to do, get a third-party perspective, because you'll be surprised what you'll learn, and you'll be surprised at people's resilience and how long they can last in the community independently when there's cognitive impairment going on. And obviously screening, Medicare beneficiaries, right, as part of the annual wellness visit, we'll talk about that a bit, right? It's a bit more controversial because, do we really want to be pan-screening? There's lots of topics in healthcare and medicine historically, right, where we have moved population to universal screening, and a little bit of controversy comes up with that because, again, you get false positives, right? And so that can, there's questions about that. Now, I would argue in the world of cognitive impairment, false positives are, I would say, not as risky as in some other cases, like maybe certain types of cancers, where false positive can trigger a significant, burden of healthcare and possible harm. But with this, it's less of a concern, so I don't find it as controversial, but certainly just keeping that in mind. We want to target, of course, people with higher risk at first. So just kind of drill down on the annual wellness visit. These are patients, whether they're in residential facilities, assisted living, or really applies a lot to the primary care clinic, or really, any outpatient clinic. This annual wellness visit is, a standard routine visit. It does dictate. So if you look up kind of the CMS guidelines for annual wellness visit, it does point out that, part of it is to assess the beneficiary's cognitive function by direct observation, with due consideration of information obtained via beneficiary reports and concerns raised by family members, et cetera. So there is a cognitive assessment component of it. Now, how you achieve that, there's variability, of course. Most commonly I see things like mini cog, some very brief instrument, whether it's like a quick clock drawing and 3-word recall, something like that. So often providers or staff will choose to use that. Really, the main thing is, I think it doesn't always happen either. I think it is worth doing, especially once you're getting into your, when you're on Medicare, you're in your 60s and older. It can really provide at least a little bit of a baseline too, in case things do change in the future. And so I think that's an opportunity to do that, because that is a scheduled visit that provides some time in your day. Again, there's no specific tool required, but I encourage folks, and we'll talk about some tool options, but you might as well go into a little more detail, if at all possible, a little more intense screening. And we'll see. CMS may at some point recommend universal tool. I don't see that happening anytime soon, but certainly a possibility. The U.S. Preventative Task Force, right, over the years has updated, their guidance, as recently as 2020. And they'll point out insufficient evidence that screening affects outcomes, but recognize a screening tool could increase detection, potentially reduce uncertainty and allow for treatment. Now, keep in mind, right, they're looking at, they're doing almost like a meta-analysis. They're looking at population level data as much as is available. And of course, in this space, there isn't a ton. And so that's why they're saying there's insufficient evidence. Now, and why screening tends to be a little bit more controversial. Now, we know that if someone does have cognitive impairment, and it's measurable and you track them and you intervene early, that clearly affects outcomes. but the idea that, if I screen like however many million people, right, over a certain age, that's not as clear. So that's why we really rely on us, all of us here, because we're the people that know these patients. We know that we can talk to the family members. It's putting all that data together that increases your chances of being accurate in your detection. So screening is, you have to be careful with that term, right? Because if we just did like a 2-question screening to everybody, yes, that's probably going to be a little bit harder. But if we really rely on as much information as possible, it will increase the utility of gathering that information and doing something with it. It's the 2020 update. They obviously no new evidence screening normal individuals over 65. So these are the people living in the community independently that are not complaining of any issues. So really want to think about people that have any hint of cognitive decline. And so just touch on quickly here, you can see, they looked at studies that use different screening tools. And so like the mini mental status exam, that was popular more, I would say, like in the 90s, maybe 2000s. That's I don't see it as commonly anymore, just kind of general trends. There's the clock drawing test, very common, very, very popular. It combines a bunch of different things. You have executive function and, not as much memory, but processing in there. So that can be helpful. There's memory impairment screen, 8-item informant interview, this 88, that's somewhat, I've seen that a bit here and there. Mini Cog, very common. MoCA is probably one of the more common ones these days. Very popular Montreal Cognitive Assessment. The St. Louis MS, the slums, that's also, some of these are regional. Obviously, that came from St. Louis, so it's more common down that way. So you can see there's quite a few to choose from. It's not meant to be overwhelming. I mean, really the key is pick an instrument and get comfortable with it so that it becomes kind of like, secondhand, just second nature for you. And so you can just jump right in and do it with someone right on the fly. You might run into someone, oh, you know what, I have a concern, just jump right into it. That way it doesn't take a lot of thinking or work ahead of time. Alzheimer's Association, had this Medicare detection of cognitive impairment work group. Informal observation, not good enough. I can definitely tell you that anecdotally and from my experience clinically, man, I continue sometimes to be fooled, if I'm just doing informal observation or just gathering basic information. People, can be very resilient, and show very well, present very well. And until you use some kind of tool, then you'll be surprised, oh, wow, I did not think you were going to have this much trouble, doing the MoCA. And so tool, staff observation, informants, and an iterative process. I mean, that's the key. Don't ever doubt yourself. No matter how confident you feel, you might think, oh man, this person's fine. Yeah, they're living in the community and they're speaking so well to me today. Definitely, if anyone has raised any concern, I think it's worth using a tool. And you can see can increase detection rate to 83% versus 59% of observation only. It's a big difference, and it's not just for primary care physicians. I mean, I still get kind of surprised, and this is pretty much all I do. A tool should take less than 5 minutes, be free, validated in primary care, be able to be administered by staff or physicians, free of cultural bias. There are a lot of requirements there. I mean, really, most of these tools we'll talk about kind of can fit that. A MoCA, does it take less than 5 minutes? No, but if you have the time, it will provide you more information. And so here's a little algorithm from Alzheimer's Association. And so again, based on everything that's coming in front of you, and whether you're in the clinic or you're in a residential facility, right, based on everything that you have in front of you, is there any kind of concern? So if yes, then that's where we're trying to argue is just jump right into a brief structured assessment, that mini cog, and we'll talk about more of these in more detail. You can also offer, right, the informant a questionnaire, and there's lots of those, FAQs and ADLs and IQ code, all of that. And that will then give you a good chunk of information to then move on. And if those screening tools are positive, then go ahead and move into your evaluation. You want to do your reversible causes. You want to, double check, any medical issues, their B12, their vitamins, their thyroid, just like we talked about. You also might do some brain imaging. don't have to do it all the time, but a brain MRI is pretty routine at this stage. And thinking about things like the sleep apnea and depression, and what are all the other considerations, and really thinking about reversible causes. And that really puts you on the path to then figuring out, is there an Alzheimer's or related dementia going on? If there's no signs or symptoms present at that point, and you're pretty confident because there's an informant that kind of, oh yeah, they're fine. Okay, that's fine. Follow up with them next year. That's really the end of that. And again, this full dementia evaluation, really want to point out that all of us have the power to at least be aware of what this entails. I don't expect everyone here to be able to do a full neuropsychological battery, of course. That takes an expert, but the basics in terms of the reversible causes, knowing what's on a full evaluation. Any primary care provider can certainly complete a dementia evaluation. I know it can be very, it can be nerve-wracking and be uncomfortable to make that final diagnosis, and that's why we have support. Sometimes you get referred to specialists. Sometimes, often in the community, it's general neurology versus geriatrics if you happen to have it, versus, not very many of me. So, but we really want to increase that comfort in advancing that diagnosis, whether it's from memory loss to mild cognitive impairment, or to major neurocognitive disorder, dementia, or even getting more specific, what kind, Alzheimer's, frontotemporal, Lewy body. Even just taking that first step, like we talked about, kind of we touched on the first session, that's a big step forward. And so here's a bunch of options for brief cognitive assessment tools. These are really good ones to keep in mind. I think again, I see very commonly the mini cog just takes a couple minutes, can be really fast in the clinic. Clock drawing test. The nice thing about this GP cog has patient and informant information. I think it's, once you're having any concern about cognitive impairment, it's really good to have some information from the informant, even if you're not using a formal tool, but really, capturing that information is pretty critical. And again, you guys can obviously, kind of look online and search the internet for these find examples, but the point is, these are all pretty brief. Whatever one you like, feel free to use, and just get used to it. There's not a huge variation here. There's a short MoCA, and so I think that's the most important thing, is just get comfortable with one. Here's just some more information about these, and really, this all becomes second nature once you get used to it, right? The scoring and all that, you really want to have to think about it. At first, you just get comfortable, and there's little rules to keep in mind. When you're doing like 5-item recall, when you're giving someone a list of words to remember, just throwing out some kind of tidbits here. Just remember, you want to make sure they register those words. What do we mean? If I list 5 words and I just kind of say it quickly and move on, I don't really know if the person listened to me, right, or heard me. So in all of these, you want to say the words, have them repeat it to you, and if they only repeat 3 of them, repeat it again. You can do it, 3, 4, 5 times, and really try your hardest to get them to repeat all 5 words. Sometimes they can't do it, and that's okay. But you really want to, as much as possible, make sure that those words get into their brain, right? It gets registered, so it gets that way later when you ask them to remember, you are actually measuring their memory and not their attention, right? Because you want to know that they have the ability to remember that. So things like that, just making sure they drill that down. The clock drawing, date, news. So this one, it shows you the scoring. Less than 5 is impaired. 5 to 8. You want to think about it. It's kind of in this medium range, and then normal is, of course, if they get a full score. So that's a quick one. Mini cog. I think I see this the most commonly, the annual wellness visit in the primary care offices. So you got the 3-item recall, so just a couple less items, clock drawing, and so it's a quick scoring. This one, again, very popular. It's very easy to do. MIS, similar. You get used to the scoring, but again, just being deliberate about making sure they remember the words, quiet, distraction-free environment, take into consideration that they're, if they've shown up and they didn't sleep the night before, or there's other, they're actively in pain, just kind of considering all that. That can really affect the scoring. Here, just drilling a little bit more into some examples here, the GP Cog screening test, right? So, and you don't have to print this out. I mean, you can kind of do this on the fly, but for the first few times, it's kind of nice to have it. but and so you give them a little bit of something to remember, paragraph form. You ask them, date, some orientation questions, clock drawing, whether they were able to do it, and this is a scoring. Remember, on the MOCA, for example, right, the clock drawing has a little bit of a different scoring. So whatever you get used to, just get comfortable with it, and don't worry about it beyond that. Ask about recent news. This is a pretty good one. I do this a lot just on the fly, asking them what they're interested in, and then drilling down and actually asking something very relevant from the recent news. And you'll be surprised sometimes with how much trouble that can cause. And then the recall, and seeing if they can recall specific information. And then you can tally up the score out of 9. So the GP-Cog does have some informant questions. 88 is a common one. Alzheimer's Association has some information online about that. Or this IQ code, short informant questionnaire on cognitive decline in the elderly. So again, any of these are fine. I mean, the point is to really give you the moment. And you can actually, have people fill these out themselves, right? So this can be done in the waiting room. You can have staff in the clinic do it that way. In a residential facility, you can have an informant do it at home. You can, especially with COVID, I know outbreaks and lockdowns, you can email it to them, have them fill it out. But it's valuable information, and it's flexible with how you gather it. So here's an example of informant interview. Remembering things that happened recently, recalling conversations a few days later, finding the right word, managing money and financial affairs, medication management, and transportation, right? Very common issues that happen as cognition declines. So again, unless we stop and ask, it's often surprising. You think someone's living independently, but turns out, their loved one or their son took over their finances 3 years ago, and you're wondering why. But that kind of stuff doesn't really always naturally come to the surface. So it's important to have these questions. Again, so the key point there is, right, pick a tool, familiarize yourself, and just make it muscle memory, integrate it in your practice. If you do that, it really takes up far less time and not as much cognitive space for your own cognition, so that, you don't kind of hesitate or get tripped up. Like, oh God, I got to go find a printer. I got to print it out. I got to do this. Pick a brief one. You can do them on the fly. You don't have to print anything out. You don't have to look for the scoring sheet, that kind of thing. Again, false positives, making sure someone's hearing you correctly, right? If their vision is significantly impaired, it's going to be hard to do the visual ones. Of course, you have to rely more on auditory. And again, people with high education or just that have been very, very independent, very high functioning, they're going to score perfect scores for a long time, while underneath the surface, something's brewing. So that's why, sometimes I think if there's any kind of concern from the person or the caregiver, I like to opt into a more in-depth test if possible, especially for people that have a higher education. Again, you can kind of be creative, having your staff, medical assistants in the clinic, or any kind of staff in any facility, right? Calling informants before or after, trying to be efficient. You don't have to do it all yourself. Bring in the team to help. And often, you can, any staff, by the way, can administer any of those tests. You don't have to be a prescriber to do those tests. And so what do you do once a screening test is positive? And for anyone in a facility, for example, I think there's a good argument there to be screening everybody, especially older folks. If you're in a long-term care facility, it's pretty reasonable to be screening. And if it's positive, then you can jump into something a little bit more, more in depth. So the full MOCA, you want to follow up with like a geriatric depression score. And we talked about, the full workup, like consider brain imaging, brain MRI, not a head CT. That's not really that helpful at this stage of things, really. If you're going to do it, then brain MRI is the way to go. But the point is, you're getting more cognitive description here. You want to rule out some of those other, things that can blur the lines. So how's their anxiety, the depression? Make sure you're not missing sleep apnea, things like that. And we'll talk about this, in the next session, and then the following session, in terms of referral. How do referrals work, right? Where do you send people? How can you find more expert support at times of like an inconclusive diagnosis? If something's weird about it, okay, it's been a really gradual, slow decline, not a lot of other comorbidities, it's very clear. Okay, I mean, you can absolutely move forward with the diagnosis. but maybe it's somebody that's had kind of a lot of ups and downs, there's some comorbidities, inconsistent information from the informant, some challenging social dynamics, all situations where it's appropriate to bring in someone like myself, or, geriatrics or neurology, things like that. Especially when there's concern, maybe there's other medical comorbidities that are not, that you're worried you might be missing. Like maybe the person is having some concern for seizures, for example. Things like that do come up. The atypical presentation, behavioral psychiatric symptoms. Keep in mind, as cognition advances, this becomes a rule, not the exception. So behaviors will change. There will be psychiatric symptoms always with advancing dementia. If someone's younger, less than 65, that's always a good idea. There's some considerations there. Family planning. That's when you can have more of a family history and genetic implication, and also sometimes diagnosis just can be a little bit harder because oftentimes early on they're still very independent, and so on. You can see there's reasons to also bring. I end up working a lot with APS and similar types of supports just in the community. And often they can be very helpful. It's not meant to be hostile, right, or punitive. It's really meant to protect patients and provide that support, and that can often be a great resource. And then bringing caregiver support with that diagnosis, with earlier detection, right, you're going to be able to support the caregiver much, much better. And keep in mind, perhaps the biggest predictor of how that patient's going to do is how their caregiver does. So if that caregiver gets burned out, we're in big trouble, right? Because we don't have facilities and access for everybody. So I harp on this a lot in clinic. And when I'm talking to patients' families, I ask the caregiver, I always pepper them with questions and make sure they're supported. I always, earlier than anyone thinks, earlier than the patient thinks, even earlier than the caregiver thinks. Oftentimes the I'm fine right now. Nope, we're going to start a few hours a week, in the home. Always earlier than you feel it, because by the time they say they need help and the several months later it takes to start that help, it's not going to go well. And so before they need the help is the time to start. And again, these are all the things that become possible with that early screening, early detection. And boy, life partners are very good at caring, for their loved one and not complaining. So keep that in mind. That's always a challenge. You got to kind of elicit that and really kind of, drag it out of them sometimes. Any questions about that material? About 15-20 minutes left, so I just wanted to make sure we got through that material. I was looking through the questions. Feel free to type them in if you're not able to jump on video or on audio.
Dr. Gomi, I did just want to point out Mary Schrampke. I don't know if you want to come off of mute, Mary, talking about, incorporating, doing some of those home assessments where the patient might feel more comfortable.
Thanks, Amber. This is Mary Schrampke. I'm a patient family advisor with Mountain Pacific Quality Health, and thanks for for getting this conversation started or keeping it going, I guess. You did mention annual wellness exams, but I was thinking that if some of these changes are somewhat subtle, if there is, and you mentioned a number of different impairment tests that you could do, if there was a recommendation you could make to both the patient and the caregiver, maybe when they came in for their annual wellness exams, to say, look, this is a way for you to just start keeping track of things, and maybe try to focus on one that's pretty simple, that but yet at the same time can really pick up some of the earliest signs so that we can work on it together. I think your point's well taken, that once you become more impaired, it's harder for you to buy in. But if you are, sort of in it as a sort of triad early on, then it's an easier conversation to have. I don't know if you can comment on that.
That's an interesting idea. I think there's certainly merit to it. I do have on, somewhat of a regular basis, families that come in and say, hey, I did this like online cognitive test thing, or, I took this quiz online, that kind of thing. I don't think that's a bad thing. I think that can at least give you some objective evidence. Some of these screening tools now, are they designed for an untrained person to do it? Not necessarily, and I mean, but could they? Sure. Now, with the mini cog, the GP cog, the ones we were looking at, yeah, of course, and a lot of those are self, filling out anyways. But a family member, for example, doing like a clock drawing test or the 5-word recall, I think it's absolutely possible, and there's nothing wrong with trying. I think that the trouble comes in is, practically speaking, when doing it, all those dynamics get in the way. Like, I don't feel like doing it. I don't want to take it seriously, or there's a little bit of leading the questioner or the person you're testing. So if I'm doing like a mocha, oftentimes I'll in the room and the family members there, I'll see them like kind of coaching them, or rooting for them, or so there's just a lot of variables there that make it very difficult to validate an instrument and do those studies to do that. That being said, I mean, I'm on the end of the spectrum of saying, well, more information the better. And if they come in and they have a concern and then they have like a score with a test back then, well, I mean, that still helps because I can still repeat the test and say, oh, look, for some reason they did normal with me. Were you, and they're like, oh, I guess I was, coaching them a little bit too much or something. So I think it's reasonable. To your point, I haven't seen it. It's not like something that's widely practiced or as a standard, but it's certainly reasonable. And I think it becomes more pertinent in rural areas where you might not have as easy access. So you can tell people, hey, try doing this at home. And we are seeing more. So one of my disclosures, right? I work for BrainCheck, which is an online computerized cognitive testing company. I mean, there's more and more of those. There's, I think, over 10 now. I mean, and Philips is one I'm not affiliated with, but big healthcare brand. They actually have a computerized cognitive test. They're releasing. So I mean, there's going to be more opportunity to do things from home too.
Sure. Just thank you, Ms. Mary. Just a quick follow-up. I think from a patient caregiver perspective, if the doctor or clinician wrote it as a prescription, in other words, say, look, you need to do this, then it puts it in a different light. Like, this is not a test that you want to coach. This is something that is just and so maybe there is either an app that you can do, but either way, I think the getting the message across from the clinician to the sort of home care team that this is something that is going to be used as a benchmark over time, then I think people would be less likely to coach and take it seriously. Thanks.
No, it's a great idea, and I think keeping an eye out. I think there are more and more opportunities to use like online tools even to do it, so it makes it even easier for people at home.
I also had another comment too about the early identification of caregiver support. And I just, from my own personal experience in dealing with my mother, it's so important to support that caregiver early on. I think we wait way too long to have those conversations. And in our rural areas, sometimes it's really challenging to find resources. I live in a very resource-rich community, but I know in eastern Montana and those places that are sparsely populated, you got to get your ducks in a row way ahead of time before you think that you need it.
Absolutely. Yeah, can't really emphasize that enough. And it just goes such a long way because you're really affecting, right? It's not just the patient, their entire family, is affected. So,
and then just another quick follow-up on that. Is there any particular, I know that in Missoula here, the Missoula Aging Services has tons of support activities. Is there online support for those communities that maybe aren't as robust?
Absolutely. I would encourage people. So, your state chapters, for example, the Alzheimer's Association, like I worked a lot with Alzheimer's Association nationally, but also, specifically in Montana. And the local chapter, they have a schedule online. You can go on there. They have groups, online activities. They've always been really helpful with those kinds of resources. So I would definitely encourage you to look there. And again, it's called Alzheimer's Association, but don't feel like you have to have the diagnosis of Alzheimer's, right? I mean, it doesn't matter. If you have any kind of memory issue or cognitive issue, it can be super important. And a lot of the help and support overlaps. Definitely take a look at that.
And questions from the group?
Go ahead and keep sharing your questions. And again, Amber, we didn't get any last second case
No, we didn't. I think we do have one for next week. So that's, or next 2 weeks. So
Okay.
that's really good.
Definitely for folks, yeah, I think any case you have whatsoever,
And
be
we
best.
know this is not an infrequent diagnosis. So you can't tell us that if you signed up for this, that you can't think of a patient.
Yeah, and it could even be like something that I think seems boring and you're not even sure it's, but any case is super helpful. Does anybody, even just now in the audience, have anyone they can think of, from the last week or two that you've interacted with? Perhaps somebody earlier in the course, or who you might have known already for other reasons, for other healthcare reasons, but maybe have some more recent memory issues or cognitive decline. Anyone you're thinking about screening and how to go about doing that? Don't be shy.
We're going to have to start like calling people out.
I'll be surprised if everyone is super shy today.
One of the things that we did before we planned this series is we did look at some of our data and specifically looked at the numbers of annual wellness visits that take place in all of our communities. And it wasn't necessarily a big surprise, but both Hawaii and Montana had very high annual wellness visit rates. And that's most likely because there's been some significant efforts from the CPC Plus communities that focused on annual wellness visits. And so there are resources that we have available if there is an interest in improving those rates in your particular clinic. We might be able to help you with that. So feel free to reach out to us. I'll stick my email just in the chat for anybody that wants it.
I know somebody's had an interaction in the last week or two with somebody with any concern of memory decline. And even if it's somebody that's not early on, I mean, any case really, even if it's somebody that maybe has known memory issues but has never been formally diagnosed.
Melissa, I see you popped your face on. Hi.
Hi. So I have a patient that I don't think she's been screened officially for memory issues. We just all know that she has them. They're significant. She takes an array of psychiatric medications and has had many ECT treatments. And so I think the assumption has been that her memory decline has been as a result of that. And so I'm working from her primary care physician's office as her care coordinator, and trying to work with her psychiatrist or psychiatric provider. And she has been referred by a previous psychiatric provider to a she has a neuropsychiatric referral out there, but we're in Rock Springs, Wyoming, and we don't have anything locally. And then having memory issues herself, she's not remembering to go schedule that appointment and get there. And so I think it would be more of like a referral question, but that'd be my case.
Yeah. Okay. So that's interesting. So and how old is this person?
She is 64.
Okay. And a long-standing depression, treatment-resistant depression, getting ECT.
Bipolar disorder.
A bipolar disorder. And then how many years do you know how many treatments of ECT this person's had?
I think the last round was 30.
Okay, so definitely quite a few. It's been over the course of probably a few years.
She generally makes it a year and then goes in for a psychiatric hospitalization, and then we'll do a round of ECT.
Got it. So it's really been ongoing.
Yeah, and so probably every year she ends up with a week or two hospitalization.
Do you know if it's bilateral or unilateral ECT?
Off the top of my head, I don't, but I could look it up and maybe resubmit her case.
Yeah, well, one just thing of note with ECT in particular is the bilateral, when you place the leads bilaterally, which more common now, I would say, because efficacy is a little bit better. That tends to be a much higher rate of cognitive impairment. And it tends to be short-term memory, almost like amnesia a little bit in terms of the nature of it. People that have that kind of memory loss with ECT it can be, but it doesn't tend to be, I guess, as functionally impairing. And so if it's something that's like a progressive nature or is more impairing, that raises my, suspicion for, is there something else going on? Or if it's no longer effective, if you did your round of ECTs or, for any treatment for that matter, and it's not helping, well, then all of a sudden you're wondering, well, maybe it's not mainly the bipolar that's driving it. So just some questions around that. Is this person on Medicare?
Yes.
Okay. Just as an aside, I could see this patient if he needed me to. We do have a little bit of in Wyoming. And so that's the kind of person where obviously the history of ECT and bipolar disorder are very, very important. But one thing I like to point out, in the psychiatry part of what I do, as we age, certainly for some people, things like bipolar disorder or schizophrenia, or any kind of severe mental illness can really still be active and require treatment. But actually, really, probably more than half of patients, the majority, symptoms tend to wane with age, and so things tend to fall in the background. So when they don't, you can always ask myself, well, what's going on? Is there something else going on? Or is it, could be someone that just, I've definitely taken an 80-something-year-old slowly off of bipolar medications after decades, and they go manic. I mean, it happens, but it's not common. Most people, they won't have that relapse. And so it is a good time once you're really entering your 60s to really be reevaluating the medications, because those can also contribute. Keep in mind, metabolism changes as you age. So even if you've been getting away with being on anticholinergics or certain medications like an antipsychotic throughout your 30s and 40s and 50s, well, you won't get away with it forever. So it tends to catch up with you. But that's a great person to do a formal cognitive test on. And because of that situation, that's when I would skip the screening. So we talked about mini cog and those things. Just jump right into like a MoCA or an MMSE is like a starting point. Maybe that's already been done. And then you can go even further if we need to. So like with me, I would do a little bit more in-depth testing than that as well. And then really just kind of look through medications, any other reversible causes, and really think that through. And with that, it's hard because, if ECT is providing relief from bipolar symptoms and it's life-threatening, well, you always have to, it's kind of a little bit of a tug of war of how much cognitive impairment can you tolerate to have that relief. So, but yeah.
I have a question for you, Melissa. Are you, as her care coordinator, are you able to make a home visit to assess for safety and, some of those other things that perhaps you would only really recognize if you laid eyes on it?
I mean, I do have the freedom as a care coordinator to kind of just do what's needed. It's kind of nice. I also have home health going in, and so I also have other people that can report to me on what's going on in her house. She needs more services than are available, like always. And then I've been working with her for several years through her primary care office, and then previously we had a psychiatrist's office, and they closed because that's what happens in our small communities. And so I've seen her functionally decline. So for safety, she lives in like a small apartment. I think her psychiatric symptoms, she needs help taking care of her house, her small apartment. And I have seen her memory decline and just kind of how much she's with it decline over the past couple of years. She hasn't had an ECT treatment in over a year. So I suspect there's something else going on as well, but I just need to get her somewhere.
Absolutely. That's a good person to have a brain MRI on as well.
Okay.
just given all that pathology. So, that can be done ahead of time. But yeah, I mean, feel free to, if you need to reach out to me and, because I can always see her virtually
Okay.
and do that evaluation. But yeah, that's a perfect example of someone to refer
We'll do
to, to get some support there. I know, obviously easier said than done, but that's a good example.
Thank you.
Wonderful. Well, I guess we're kind of coming up on the hour now. I really appreciate, the questions and participation. And again, even now, if you have a couple minutes before the week gets away from you, fill out that. And the form is online. Is that right, Amber? Is that where you?
Usually I send it out like
Okay.
about
So
ahead of time. So most people,
you
if
got
you,
it,
if you just search on your emails, you'll find my email and you'll see
Yeah,
the
look-
case presentation form. Plus, you
Yeah.
can always go on the website.
look for Amber Rogers in your email and just, again, it can be brief. Don't worry about filling in every field. Fill in as much as possible. I can always follow up with questions beforehand, but would love to have some more cases for next week. Of course, appreciate everyone participating. And please fill out your evaluations. That's in the chat. And then next week, we'll be talking about evaluation and diagnosis in the primary care office or residential setting. So we'll get more into a little bit further, right, beyond screening, but evaluation and diagnosis. Thanks, everybody.
Okay, thank you. Bye-bye.